Hello everyone, good morning. This is a quick disclaimer that the questions discussed in this PPT are all recall based, and the motive of this session is to get the actual questions through the discussion that we do through the session now. The final questions will be uploaded onto the PrepLadder app once we have reviewed the entire thing. Okay, so let's go with the questions. So we'll start with impaired gag reflex. I think this is a very basic question. Impaired gag reflex is seen due to lesion of which cranial nerves? 5 and 6, 10 and 11, 9 and 10, and is it 7 and 8? Can you all tell me where do you get impaired gag reflex? I'm sure everybody knows this. So whenever we're talking about gag reflex, we are talking something related to our oropharynx, where we want to know the sensory and the motor supply of the palatal muscles. We want to know the sensory supply of the palatal muscles and the oropharyngeal mucosa and the motor supply as well. So the sensory supply is via the glossopharyngeal nerve, and the motor supply to the palatal muscles is via the vagus nerve. So the gag reflex will be impaired when the sensory and the motor component are lost, which happens due to 9th and 10th nerve involvement. So I think this was a quite easy question. Let's go to the next one, which is which of the following procedures would be difficult to perform based on the given chest X-ray? So they have given you an X-ray and have asked you what would be difficult. Can you all quickly answer? So you see there's something here. What is this? Can you all tell me what is this that you see? Do you see that there is a shift in the trachea? Yes. So if there is a shift in the trachea, what is going to be difficult? So typically accessing the trachea will be difficult because the trachea is shifted to one side. In such a situation, doing a tracheostomy or intubation are the two things that's going to be difficult. LMA is going to be above the larynx. We put the LMA mask above the larynx, so it's not going to be difficult. Ryle's tube insertion may be difficult, but not so much as going and accessing the trachea via tracheostomy or intubation. Now, tracheostomy we do either via an open approach or percutaneous approach. The percutaneous one is going to be very difficult, whereas open approach you can still access because pre-operatively you know what is the position of trachea. So this is relatively less difficult as compared to intubation, which is going to be more difficult because you're not accessing the trachea directly, or you're not seeing the trachea directly. You're just trying to blindly insert the tube through the larynx into the trachea. So the answer should be intubation. If intubation was not the option, then you go for tracheostomy. Okay. So let's go to the next question, which is a 14-year-old child with a history of recurrent nasal bleeding has an endoscopic view provided. What is the investigation of choice? So here we have 14-year, we have a child, and we have recurrent nasal bleeding. I know everybody of you would know that this is a diagnosis of JNA, juvenile nasopharyngeal angiofibroma. There is no controversy to it. So we have an endoscopic view which shows that there is a mass which is lying posteriorly in the nasopharynx. And now since the mass is lying posteriorly in the nasopharynx, we know our diagnosis further better. Now, what is the investigation of choice? We already have learned this multiple times in our revision sessions, in our rapid revision. Eat it, try it. This is why I'm trying to tell you that we have covered all the 3 questions so far in our rapid revision as well as the main videos. So don't worry about what is covered and what is not covered. Trust us, we have done everything possible in the rapid revision. Right. So here the recurrent nasal bleeding JNA, the investigation of choice will be a contrast enhanced CT scan because JNA is vascular. So you will require a contrast. And the second thing is it is a locally invasive lesion. So since it is a locally invasive lesion, we want to identify involvement of the bone, which is why we will do a CT scan. So a contrast enhanced CT scan will be your answer. Right. Now let's go to the next question. They have asked you identify the marked structure in the image given below. So they have given you an image and they have marked you something here. So they've asked you what is that structure. So is this electrode, is this coil, is this magnet, or is this a processor? Right. So basically cochlear implant CI surgeries have become one of the novel treatment methodology for children or adults who have bilateral profound sensory neural hearing loss, especially if they have cochlear type of hearing loss. So we have cochlear implant as a solution for those people who have both sides profound hearing loss. Now, what are the parts of the implant? So if you see on the outside, we have got the microphone. This microphone receiver will receive the sound and transmit it to the external transmitter, which is connected to the scalp on the outside. Now, this external transmitter is electromagnetically communicating with the internal receiver. So, on the inside in the squamous part of the temporal bone, while doing the surgery, we keep this receiver and they are both connected via a magnet system. Now, from the transmitter or the receiver, you have got two electrodes. One is going into the cochlea, which is called as your intracochlear electrode. And the second one is called as the reference electrode or the ground electrode. Okay, so we have intracochlear electrode and we have a reference electrode or a ground electrode. So intracochlear electrode will go into the cochlea and stimulate the cochlea with the sounds. Whereas ground electrode or reference electrode will see how much is the stimulation. Is it efficiently stimulating or not? Do we need to modify the stimulation? Do we need to increase or decrease? So that part of information is going to be done by your ground electrode. So basically the question just asked you electrode array. So you should answer it as electrode. Okay. So I think this is sorted. What is the sinus drainage that has got blocked or impaired in the following image? A very, very easy question. They have asked you a image-based question and pointed to a sinus which is in the cheek below the eye. So this is your eye. Below the eye in your cheek is going to be which sinus? It's going to be your maxillary sinus. So you can typically see that there is fluid level over here. So fluid level over here would suggest to you of maxillary sinusitis. Okay, so whenever there is an obstruction to the drainage, so where it drains, if there is an obstruction, there will be retention of secretion. And when there is a retention of secretion, it will result in sinusitis. Okay, I think this was quite easy. Identify the following device. Is this nasopharyngeal airway? Is this laryngeal mask airway? Is this oral airway or is this a oropharyngeal tube? What is it? So basically LMA is like a face mask, but it is a very small kind of mask that you insert via the oral cavity and keep it over the larynx. This is definitely not a LMA. Oral airway is typically rigid. It's not, flexible, and it is usually white in color. So this is not oral airway as well. So this is going to be your nasopharyngeal airway. Whenever we do a nasal intubation or whenever we want to secure the airway where mouth cannot be opened, like maxillary mandibular trauma, or if the patient has trismus, now you want to secure the airway, then you can do via the nasopharyngeal airway. Great. A female patient, a pure-tone audiometry finding showed the presence of Carhart's notch. What is the most likely diagnosis? See, very easy. We know that Carhart's notch will be seen in which condition? It is seen in which condition? Very good, everybody. It is otosclerosis. Now, in otosclerosis, what sign will you see? You will see the Schwartz sign. What is Schwartz sign? That is flamingo pink appearance of the promontory seen through the intact tympanic membrane. This sign is called as Schwartz sign. So now this is also covered in our rapid revision. Cochlear implant was also covered in our rapid revision. So don't worry, we have done everything that we're discussing so far in our rapid revision. Now we have Hitzelberger sign. Hitzelberger sign is loss of sensation in the posterior meatal wall, and this is seen in which condition? This is seen in acoustic neuroma. Okay, Henneberg sign is false positive fistula test. Whenever there is a fistula test and it is falsely positive, we call it as Henneberg sign. This is seen in congenital syphilis and in some patients with Meniere's disease as well. And of course, Carhart's notch is not a feature of Meniere's disease. On audiometry in Meniere's disease, you get a upsloping type of a graph. So the answer is Schwartz sign. So let's go to the next one. And this is not covered in a rapid revision because this is generally not a question for undergraduates. It's a rhinoplastic question. So it's usually for the postgraduates, but there will be one or two bouncers that they will ask you in the exam. Okay, so for which surgery is this incision given? Now you can typically note that this incision is given on the external part of your nose. So you have to tell me what is the surgery that you're planning to do. Is it open rhinoplasty? Is it Caldwell-Luck procedure? Is it septoplasty or is it sinusotomy? So even if you didn't know this, how would we rule out? Cardwell procedure, it cannot be because we go through the sublabial route. So we go through the sublabial route and go into the maxillary sinus. Septoplasty is via the septum. So we go inside where we take a Freo's incision or a Killian's incision on the septum, not on the outside. Sinusotomy is a part of your fess. So again, you will have an endoscopic image, not this image. So of course, even after ruling out, you can understand that this is an open rhinoplasty incision. Very good, Shubham. That is the answer. Based on the provided image of septal perforation, which surgical procedure is most likely to have been performed in this patient? So you see here, there is a perforation here. Can you tell me what is this perforation? Most likely. See, whenever there is a septal perforation, it has to follow a septal surgery only. Now, septoplasty and SMR, we have two surgeries. Septoplasty is a more conservative surgery, whereas SMR is a more radical surgery. So the answer will be submucosal resection of the septum. So the answer is SMR. Inferior meatal antrostomy will be here. We will make in the inferior meatus an opening. FES would show you typically images across the middle meatus. Turbinectomy typically will show you either image of here or here. Okay. What is the staging used in the image given here? It's Cotton-Myers, is it Redkowski's, or is it TNM, or is it AJCC? So you can see this is your vocal cord, and below the vocal cord, there is narrowing of the airway, which we see in patients with subglottic stenosis. So whenever there is a subglottic stenosis, the classification that is used is going to be your Cotton-Myers classification. Redkowski's classification is used for JNA. TNM is used for cancers. Again, AGCC is used for nasopharyngeal cancer. So we're not going to go there. This is a subglottic stenosis. So the classification used is called as your Cotton-Myers classification. So what is Cotton-Myers classification? This we have included in our RR. Don't worry, this is done. So all those who are thinking that RR में ये सब नहीं है, it's just that you have to see where is it. You don't read completely and then you say that RR में नहीं है, then it's your problem, right? So this all the things are covered in your RR. So grade 1 is no obstruction to 50%. So you can see that the lumen has narrowed maximum up to 50%. Grade 2 will be if the luminal narrowing is between 51 to 70%. Grade 3 is luminal narrowing somewhere between 71 to 99%, and no lumen at all, no detectable lumen is going to be your grade 4 stenosis. So grade 1 is 0 to 50%, grade 2 is 51 to 70%, grade 3 is 71 to 99%, and grade 4 is no lumen at all. Okay, so I think this were the questions. Other than this, I think there was a question on staining that they had asked on a lesion of the vocal cord. And since pathology, Dr. Preeti Sharma ma'am has already covered it, I didn't add it here. But for all those who were asking me that stain kya tha, so they had given you a vocal cord lesion, and they had asked you what is the stain used to differentiate the site or the area where you have to take the biopsy. So the procedure that we do is called as contact endoscopy. So what is contact endoscopy? So when I am doing a laryngeal examination under GA or under LA, we will see if there is a lesion. We want to take the right side for biopsy. Now, how do I know which site is the right side? Is this the site or is this the site? How do I determine? So for that, I will stain the lesion with 1% toluidine blue. Okay, so 1% toluidine blue or methylene blue, we can use one of these. And once you have stained the lesion and then you put a contact endoscope over that lesion, you can see areas which are dysplastic, the areas which look more abnormal. And from that area, you take a biopsy and send it for histopathological examination. So that is going to be your answer. It's going to be methylene blue or toluidine blue. And if you didn't have that answer, the answer in that option, the answer will be supravital staining, where you have got new methylene blue as a type of supravital stain. Okay. Yes, there was a question on Rinne's test, right? So whenever there is a perforation in the tympanic membrane, the amount of hearing loss, how much is the amount of hearing loss? The amount of hearing loss usually with a tympanic membrane perforation, even with a small perforation, will be somewhere between 25 to 40 decibels. Now, if there is a hearing loss of 25 to 40 decibel, what will happen to Rinne? Rinne will be negative because this is an conductive pathway lesion. So whenever there is a conductive pathway lesion, there will be conductive hearing loss, and in conductive hearing loss, then they will be negative. So even if there is a small amount of small perforation, 25 to 40 is the amount of hearing loss that you can expect. And if there is a 25 to 40 decibels of hearing loss, Rene will be negative. Okay. X, I didn't understand. What should I talk about? So there was a question on glomus tympanicum as well. So if they have asked you a question where there is a tumor originating from the promontory, so they told you that there is a vascular tumor originating from the promontory, then the answer will be glomus tympanicum. Okay, so that is your answer. Okay, so I think this is clear. They had given you a very clear question where they had told you that there is a tumor that is originating from the promontory, then it is going to be glomus tympanicum. Chowda Hitesh, false positive Rinne's test is seen in unilateral, not in bilateral. Unilateral, severe to profound hearing loss. What is severe to profound hearing loss? If it is hearing loss of more than 70 to 90 decibel, then you will tell that it is severe to profound. Now, in our pathology, we saw it was only 25 to 40, so we are not going to tell false positive Rinne. Okay. So with this, I think I have covered almost all the questions. I think there was a question on nerve supply of the external ear as well. And I'm sure that everybody knows this nerve supply of the pinna, where you have auriculotemporal nerve. It's supplying the lower half. Upper half, you have got the auriculotemporal, we have the greater auricular nerve at the lower half, auriculotemporal nerve at the upper half, and lesser occipital nerve supplying the least portion of the pinna. A portion of the pinna in the region of concha and the posterior meatal wall are supplied via your 10th nerve and via your 7th nerve. So this is quite easy and simple question. I think rhinoplasty by per se is not a topic that we would expect, for undergraduates. I must have discussed it one of the sessions, but it's something that we do not take into consideration for undergraduates, because they probably should know about, septoplasty, SMR, turbinoplasty, FES, and rhinoplasty is more of a postgraduate level question. But any which way, every exam will have one or two questions which are bouncers from each subject. So this was one such bouncer, but otherwise I think relatively all the questions were pretty simple from ENT. So with this, I think all the questions are done, and I hope you've done your exams really well. I'll be waiting to hear from all of you. All the best for your results, and let me know once your exams are done how your results were, and take care and bye-bye.